Thanks. I think I'm going to forego slides in the interest of time. I approach this from someone whose background in public health research, but mostly someone who's working in the arena of policy now. And so I'm going to sort of take a broader, more macro view. I want to suggest that as we think about education and training, we need to broaden our scope and help clinicians and others see addiction within a broader context and sort of move beyond specialty training and put the issue of addiction and drug use into a much wider context. I also want to suggest that when we're thinking about education and training, we really need to think about providers beyond clinicians and other sectors that folks are going to intersect with and interact with, especially if we want to think about innovative policy ideas to expand access to MAT. So in particular, when I think about this and think about a public health approach to expanding access to medication-assisted treatment, I want to talk a little bit about the social determinants and think about how are we providing people the supports they need to get healthy regardless of their current drug use, whether they're on medication-assisted treatment or not, so housing, jobs, and the kinds of social support that people need. I also want to suggest that part of what we need to be addressing, if we want to address stigma, is ending the criminalization of drug use entirely and setting aside strategies that rely on punishment and coercion. I don't see how we can talk about ending stigma on the one hand and continue those practices and punitive policies on the other. I also want to suggest that part of the conversation about access to medicated-assisted treatment also needs to include attention to harm reduction services. If we believe that relapse is part of the course of addiction, then we need to be giving people supports when they relapse and when they use, and keeping them safe and healthy. And I think we've done a terrible job of integrating treatment services with harm reduction services. Those two silos hardly ever speak to one another, are not well integrated, and that doesn't serve patients well at all. The other thing I want to suggest as we think about education and training is that we really need to be listening to people who use drugs. Whether they're current users or former users, they need to be in these rooms. They need to be part of our education and training. They need to be part of our policy development. I will tell you, as someone who's done a lot of policy development, when you don't include people directly impacted, you end up with really poor policies that have a lot of unintended consequences and are not well liked by the people that we're trying to help. So I really want to emphasize that. Obviously, MAT is only a piece of the puzzle. And it won't succeed if we're not addressing these other social determinants in broader contexts that make up people's lives. I also want to suggest one way to do that and make that shift is to start looking at outcomes other than abstinence, but to really be focusing on things like quality of life, family reunification, sort of stabilization and normalization of everyday living, getting jobs, housing stability, that kind of thing. And then talking a little bit about other arenas that I think we need to pay attention to in terms of education and training. And I apologize that I wasn't here for the first part of the session, but I think obviously correctional settings are a huge area where we could do a lot more to expand access to MAT. Whether that's continuing MAT for those entering correctional facilities, screening and assessment for those entering who may or may not be on MAT, compassionate withdrawal for those who choose not to stay on MIT while they're incarcerated, offering people inductions prior to release, creating warm handoffs to community providers upon release, and obviously there are some jurisdictions that are doing this quite well, and then making sure that people have naloxone and harm reduction referrals upon release as well as referrals to treatment. So obviously if we're going to do that, the impact on education and training is that we need to do a much better job training all the folks in that sector, from drug court personnel to correctional personnel to probation and parole. And then finally, I want to talk a little bit about some of the innovations, service delivery model innovations that are being floated and piloted in some jurisdictions and thought of in others, because this also has implications for workforce training. So one is office-based methadone, delivering methadone and buprenorphine in pharmacies, induction and maintenance in emergency departments, homeless and housing programs, street-based medicine and harm reduction programs. These are all areas and programs that are ripe for reaching people that are hard to reach, telemedicine and the ECHO model for rural areas, the hub and spoke model, mobile delivery. So there are lots of different innovations around expanding access to MAT, but that's obviously going to have implications for workforce development. That means we need to be training pharmacists, we need to be training primary care, family medicine, emergency medicine, rural providers, housing providers, homelessness service providers, right? It really means an incredible expansion of the kind of education and training we're doing, including, frankly, harm reduction providers as well. So finally, in terms of I think the kind of content ideas around education and training, obviously acknowledging and addressing head-on stigma, not just stigma around drug use, but frankly stigma by providers. Because having talked to a lot of folks entering programs and people who use drugs, they do not feel welcome almost anywhere they go. And so not just in medical settings, but in all the settings I mentioned, we have to do a much better job. Again, I think there needs to be direct training of clinicians and other providers by people who use drugs. I think we all need to hear from their experiences. As people have already talked about things like instituting medical school and residency training requirements on addiction. What I would add is that those programs need to include training on harm reduction as well. And I think I just want to wrap up by saying my take-homes really are that needing to involve people who use drugs in crafting policy solution training and education, as well as in the research that we do, that they should be helping us formulate the research questions and research design, addressing stigma, especially among providers, integrating harm reduction education and training more thoroughly throughout the systems, and helping providers of all kinds think beyond MAT as the solution to addiction and have a broader social determinants frame that also takes into account things like housing, the social safety net, employment, and training. Thanks.